My name is Dr. Kimberly Davis, Senior Research Scientist and the Director of Community Outreach for the Center for Cancer Research and Therapeutic Development at Clark Atlanta University. I welcome you to this edition of Life Notes. Today we will talk with our guest about lung cancer. Lung cancer is the leading cause of cancer death in the U.S. in both men and women. It is also one of the most preventable kinds of cancer. At least 4 out of 5 cases are associated with cigarette smoking, and the cause and effect relationship have been extensively documented. An estimated 24,900 cases of lung cancer is expected to be newly diagnosed among African Americans in 2014. Cancer of the lung is the second most common cancer in both African American men and women. Common symptoms of lung cancer include a cough that doesn't go away and gets worse over time, constant chest pain, coughing up blood, shortness of breath, wheezing, or hoarseness, repeated problems with pneumonia or bronchitis, swelling in the neck and face, loss of appetite or weight loss, and fatigue. Doctors diagnose lung cancer using a physical exam, imaging, and lab test. Our host Paulette Payne sat down with our guests to talk about lung cancer. She joins us now with more.
Thank you, Dr. Davis. I'm here at Grady Hospital talking with Dr. Eric Flenaugh to find out why the incidence rates for developing lung cancer are so high and what you can do to keep yourself and your family healthy. Dr. Flenaugh, thank you so much for joining us today on Life Notes.
Thank you for having me.
So we were talking earlier about some of the earlier signs of lung cancer, and one of those signs or symptoms is a constant persistent cough. What are some other things our viewers can be, on the lookout for?
Unexplained shortness of your breath, not being able to catch your breath or breathe that you were in the, previously, that's come on without evidence of having sort of an infection or a cold or anything. If you cough and you seem to, every now and then you cough up and you see little streaks of blood in it, that's a telltale sign too. And we get concerned about some of these things that persist because we know that by the time that lung cancer, which is a silent spreader, gets to the point where people are actually having symptoms, it's usually pretty far advanced. So we want to try to pay attention to some of these early, get them assessed early, so we can get a diagnosis and treatment.
So a patient finds that they have this persistent cough. Should that be something they should get concerned about? Should they immediately seek treatment?
Yeah, I think if they have that history of long tobacco use, somewhere between smoking a pack a day for maybe 10, 15, 20 years, then that might be the person that would want to talk with their physician about the opportunities for getting screened to see if they have lung cancer.
And so talk to us about some of those screenings. What can patients look for?
Yeah. So a couple of years ago there was a huge screening trial that came out. It's a national lung cancer screening trial. It's one of the first ones that actually found that if we screen for lung cancer, we could actually improve some of the survival rates by catching it early. What it would entail is that they have, cough, they see some blood, whatever else. They know that they've smoked at least 30 years, at least a pack a day. And they're somewhere between the age of 55 to 74. That's what they came out and say that that's the person that should get a screening CAT scan. It's a very low dose of radiation that they get. It's a very quick scan where they run through and they take images of their chest, and then it's reviewed with strict criteria looking for whether or not there's an abnormal spot or nodule that they see that would need to be worked out.
And if this nodule is present,
yeah,
what's the next step?
The next step would be then to their primary care doctor would arrange to either get a biopsy if it looks suspicious for cancer, or to sort of follow it and see if it changes over a period of time, just depending on the appearance of it under sort of established criteria.
Okay, and so once this nodule is detected and it's positive that this patient has lung cancer,
yes,
what types of treatment are available?
There are 3 main forms of treatment. There's one which requires surgery, another which would require chemotherapy, and then radiation therapy. The best chances for cure for somebody with lung cancer is surgery. just to go cut it out. It's been known for years that lung cancer is not a good responder to chemotherapy and radiation therapy alone. So if I had lung cancer, hopefully it would be caught early enough to be able to have it removed with surgery.
And so surgery is that removing a portion of the lung.
Yeah, they would go in, localize where the actual cancer is, and then remove that cancer, but making sure that they got all the little cells around it as well, so completely removing that region, yes.
And so, doctor, talk to us about the staging, because I'm sure staging impacts the survival rate, this long-term success rate of...
It impacts it greatly. Because the best chance for getting a cure from lung cancer is to have surgery, a lot of the staging has been based on your likelihood of being able to undergo surgery. And they're looking primarily at where the location is and how much it has spread. Staging usually goes through 4 stages, with one being a very early, maybe a small nodule that's in one region, there's no lymph nodes involved, and all the way up to a stage 4, which is the late stages, where it's spread to other parts of the body or has become too extensive that it can't undergo surgery. And then there's stages in between the 2 and 3, depending on how many lymph nodes or the size or the location it is. Somewhere between 2 and 3, your chances of being able to undergo surgery start to decline. It doesn't completely decline, just depending on some of the characteristics and locations and how talented your surgeon is to remove it all. But it becomes more tricky. And so for stages 1 and 2, surgery is going to be a primary component of the treatment process. For stages 3 and 4, it's probably going to be leaning heavily on getting chemotherapy or radiation therapy in the treatment, and considering later whether or not surgery could be possible.
And so for stages 1 and 2, where the surgery is the primary form of treatment, what's the quality of life like once a portion of the lung has been removed?
The patients are assessed before they undergo surgery to see what their, we term it as their performance status is, and what their baseline lung function is. You know, when one of the biggest risk factors for developing lung cancer is tobacco use, which also causes diseases like emphysema or chronic bronchitis, which limit your lung function. So they come to this lab, it's actually across the hall, and we do breathing tests to assess what their underlying lung function is, and then we can calculate, if we remove a small part, what their function will be afterwards, or if we have to move a large part, would they be a candidate?
And so there are tests done in advance to make sure that this resectioning would be optimal or would be a success in this individual patient.
Yes, yeah. There's you know the stagings as we discussed earlier, and then there's also sort of the performance assessments. You know, are they functional at a baseline? Do they have, not have a lot of cardiac disease or other comorbid conditions which make them a high surgical risk? And do they have enough functional lung reserve to undergo the surgery with part of their lung being removed?
Now, we were talking earlier about, of course, the treatment options and the diagnosis and things of that nature, but we were also talking about the population, and the number of African Americans that are diagnosed with lung cancer is pretty high.
Yes, it is. And the African American population has one of the highest lung cancer rates amongst all racial and ethnicities. There's some theories, whether it's based on the genetics or tobacco use exposure, or even some environmental factors that may be playing a role. We do know that the common factor for all lung cancers is tobacco smoking. It causes about 95% of all lung cancers. But we also noticed through trends and looking back that African Americans develop lung cancer at an early age with less tobacco use history, and have worse disease at the time that they're diagnosed.
And that's pretty alarming.
Yes, that's very alarming, especially for the patient population that we serve here at Grady, but even so across the nation. Because then if they have a later stage of cancer at the time they're diagnosed, their chances of survival decline rapidly.
And what age group, I know we were talking about earlier in the African American population, younger people are diagnosed typically, but generally, what's the age in which this disease typically impacts?
You know, and that's some information that we learned from the screening trial that was done. The recommendations came that for people that are aged between 55 and 74 years of age, that's the population where you're going to get the most benefit from screening them in relationship to diagnosing and detection. So 55 to 74, for those patients that have smoked pack a day for about 30 years and haven't quit within the past 15 years. What we've seen here at Grady is that our population tends to come in at a younger age, almost 10 years younger, with still advanced disease, and only may have smoked about 20 years a pack a day. So that was a little bit alarming, because what the recommendations were to screen this age, when we looked at the numbers that we were actually diagnosing at a younger age, we found that those recommendations for our patient population, we're missing about 17% of the patients just using those criteria alone. So we had to make some adjustments in who we felt were high risk and deserved to be screened. And
it's wonderful that you went back and you reviewed those numbers, because when you have a higher incidence rates among a particular population, you have to go back and re-examine.
Yes. That's your target population. If we fail to address the high-risk populations, we're contributing to disparities in healthcare.
And that's a wonderful point to end on. But before we end, is there anything else you'd like to share for those who are watching that are concerned, if not for themselves, but for those who they love?
There's a few things. Those patients or family members that are smoking, now is probably the time to quit. Actually, yesterday was probably time to quit, but especially now. But if they have symptoms which they can't explain, they have a persistent cough which carries on, then maybe sometimes they see small streaks of blood, or all of a sudden they have difficulty with breathing that wasn't there before, or they may find themselves being treated for pneumonia several times a year by their doctor that just doesn't seem to be resolving and stays in the same place. That's the patient that probably needs to go sit down and talk with their doctor about undergoing screening.
Dr. Flenaugh, you have shared some very vital information with us, and I'm sure our viewers are very appreciative. Thank you for your time and for your expertise.
Thank you for having me.
And thank you for watching. We'll be right back with more Life Notes after these messages.
Every budget, so don't accept defeat. Now you can get covered and still buy me treats.
You take care of your pets. Now it's their turn to take care of you. Visit getcoveredamerica.org to learn about your health insurance options.
Every day across America, excess food is gathered by a network of good people at local food banks, giving hope to millions of children who struggle with hunger. They've earned their wings, and you can too. Together, we can solve child hunger. Support Feeding America and your local food bank at feedingamerica.org.
I'm only 17, but I know about investing. Believe in something, buy shares in it, watch it grow. So, what if you could invest in the future? The future of kids, like a stock. Not the kind of stock that's about making money, but a stock for social change. A whole new kind of investment called Better Futures. When you invest, it helps kids go to college. I could be one of the first college graduates from my family, the first philanthropist from my neighborhood. And if I'm the first, then maybe there's a second and a third. Believe in us, invest in us, watch us grow. My name is Sydney, and I'm your dividend.
Welcome back to Life Notes. It's always my privilege to share stories about people who have traveled the uncertain road that is cancer and survived. My guest today is no different. Not only has she survived, but she's living a full life and helping others do the same. And today I'm joined by Sharon Cunningham, who I tell you, she has an amazing story of survival, and you'll definitely want to stay tuned. Sherry, thank you so much for joining us.
You're welcome.
So tell me, how did you know something was wrong? I understand you are a survivor of lung cancer.
Yeah.
When did you discover something was wrong?
Back in 2010, in January, I just had a regular bout of bronchitis, and so I just, went to get some medicine for that, and then I just kept getting it over and over and over again, and I had a constant cough that wouldn't go away, a dry cough that wouldn't go away. Even when I wasn't really being treated for bronchitis, I always had this cough. And I was singing in a choir at the time, and I had to quit singing because every time I took a breath, I coughed. And so then by September, I actually coughed up some blood, and so I knew something was really wrong at that point. So I went back to my internist. They did an x-ray, saw something on the x-ray, ordered a CAT scan, saw something on the CAT scan, ordered a biopsy, and then the biopsy showed that I did have fluid in the lungs, and I did have non-small cell lung cancer.
And when the doctor told you you have cancer, what did that do to you?
Well, I was just coming out from under the biopsy, the surgery that they did to remove the fluid, and I just was so shocked. I mean, it was just sort of incredible that they actually said that. I was, I just couldn't hardly believe it. I wasn't devastated about it. I was just very surprised. It was just kind of a shock.
Now, did you have a family history?
No. My grandfather had emphysema because he smoked a lot. I did not smoke. I never smoked. I didn't live with smokers, so it was even more of a shock because I didn't realize I was at risk in any way.
And a lot of the research points to the fact that you don't have to be a smoker, and many people who develop lung cancer are not smokers.
Very true, and more so, and even in women, more and more so. So yeah, it's unusual.
And so, at what stage?
I was actually stage 4, which also shocked me.
Stage 4. Now that's the stage at which people, they get I hate to say this, but the death sentence.
That is
quite
exactly
honestly.
right.
And you're here.
Right. Yes, I'm still here. Thank God for that. But yeah, but I think, that you just have to realize when you get that diagnosis that it is not a death sentence. They have made so much progress in medications that can target the particular type of, metabolic makeup that your tumor is, that they are able, if you're a match for certain ones, then you can take those drugs and that inhibits the cancer from growing. And so, unbeknownst to me, my doctor had sent away a biopsy, and it had been being tested. It took quite a few months for it to be tested and for the results to come back. In the meantime, I'd gone through quite a bit of treatment, but when it did come back, it turned out it was EGFR mutation. That means nothing to the layman, but it was a certain mutation that they had developed a drug for that could inhibit the growth of that. And so that's what I started taking eventually. That I got onto that. So, so that's what we're trying to, we're trying to educate the public to know that everyone that goes in with a cancer diagnosis definitely needs to have that testing. Because you don't know if you're going to be a match or not.
That's
and
right.
If you are, it's great.
That's right. And I tell you, you look phenomenal.
Well, thank you. I feel great. I really do. I have a very normal life. I might get a little tired, but then at my age, I would probably get tired anyway. But I really do. I have a very normal, full life. And I'm very amazed at, that the fact that I've just been, it'll be 5 years this October I was diagnosed.
That is phenomenal. 4
years this coming July that I've been on the target drug.
Wow, that is amazing.
So, yes,
that is amazing.
Yes.
And I understand you got treatment at one of our partner hospitals.
Emory is a fantastic place. Very high in research. It's the Winship Cancer Center. And Dr. Ramalingam is my doctor, which I felt very blessed to get him as a doctor because he really is right up there, tops in research, and knows the latest of everything. So when I was diagnosed and we started treatment, he put me on the regular chemos, which I call kitchen sink chemo, a couple of pretty tough chemo drugs, and infusions were like 5 hours every 3 weeks. And you know, you had the usual, you know, side effects from that, which weren't great. But then he also asked me if I wanted to be in a clinical trial, phase 1, and I said yes. And I was in that for a while. At some point I finished that, and I also finished the other chemo treatments because I was developing a little bit of neuropathy, which, you know, is the nerve endings, and he didn't want that to get worse. So he then put me on a maintenance infusion drug, which was just 10 minutes of infusion. And that just held me totally stable. I did great during that period of time, no side effects. And then the testing came back. And one day he walked in with a huge smile on his face and he said, "I have good news." And I said, "Oh, great, I'm always ready for good news." And he said, "You are a match for one of the really good target drugs." And I didn't understand anything about it at the time. And I just looked at him and said, "Well, what would you do?" I mean, because there were side effects, not horrible, but you know, you can manage them. And I said, "Well, what would you do?" And he said, "I think I'd try that drug." I said, "Okay." So from then on, I've been on 1 pill a day.
1 pill a day?
Yeah, 1 pill a day.
And this is the maintenance, if you will?
No, this is not maintenance. This is the inhibitor drug.
This is the inhibitor drug.
This is the target drug that inhibits the growth of the cancer.
Okay, okay.
And so yeah, it's one of the latest, but they're continually getting more and more. The scientific research is developing more and more target drugs, even for other cancers besides lung cancer. And now the latest thing that they're working on, and I'm certainly no expert in this, but it's called immunology, and it is a way of getting your body to fight the cancer with your own immune system. But I can't give you any other details because I don't know that much about that, but it's very exciting.
Well, I'm
They're
sure
definitely working on it.
I'm sure we'll cover that in another show.
Yeah, good.
But for the benefit of our viewers, so you've been 5 years cancer-free.
Mm-hmm.
What types of maintenance or what types of follow-up does your doctor do with you? Okay,
well, of course I take the pill every day. Tarceva is the name of the pill, not that that necessarily matters to anybody, but other than that, I just go every 4 months and they do a CAT scan just to make sure everything is looking all right and everything's stable. And then I have lab work done. They just keep track of everything, white blood cell counts and everything like that. And I see the doctor, you know, and he gives me the results of everything, and that's it, every 4 months. In fact, I just had the CT on Monday. And then I'll see Dr. Ramalingam on next Monday. So yeah. So every 4 months, and that's all I do.
And so life has been just normal and wonderful.
Yeah, it really, really has. I've been very blessed.
Well, Shari, in closing, what would you say to those viewers who are hesitant? They may have noticed some bronchitis that's been reoccurring or a cough that won't go away. Mm-hmm. What would you tell that viewer who is hesitant and scared, to be quite honest, to go to the doctor?
Well, don't ever put anything off. And the thing of it is, it might be scary, but it's much scarier if you don't address it and take care of it. Because if you catch things early, certainly things can be taken care of. And even me, with the stage 4, it came up so quickly. I had no clue, but it was just one of those things where I knew there was something wrong and I needed to go. And I'm not one that waits to go. I do go because I want to keep healthy and do the best I can to take care of myself. So my advice is go. First of all, just go. Just make an appointment and go, even if it's just your regular doctor. Tell them your concerns, and then they will go ahead and look into it. And then the other thing is, do your research when you are picking a place to have your cancer treated and you're trying to find a good doctor. Really do your research, because there's so many great cancer care centers around the country, really. But Emory's one of the best, and we've got it right here at our back door. So do your research and educate yourself about it, about the centers and about where you should go and the type of treatment that you will be getting there. And because they are very good and top-notch in the research, it's a good choice. It's a good choice. But there's many other places, too, that are very good in research. So do that. That's my advice on the physical level.
Mm-hmm. And that's wonderful advice, because we've said it time and time again, knowledge is power, but it's only power if you use it.
Exactly.
Certainly. Exactly. And Shari, thank you so much for sharing your knowledge and your power and your story of survival with us. We really appreciate you joining us.
Actually, it's a twofold advice thing. The other part of that advice is get in touch with your spiritual life. You know, be aware that there's so much help and power out there and support for you personally and emotionally. And I just feel like if you have a great attitude and you have good faith, then it goes a long, long way, because your mind and body are so connected, and you need to have that strong spirit and that strong faith to stay positive. So,
and I feel your positivity and your energy and your strong, happy spirit.
Yeah,
and,
I'm happy.
And thank you for sharing that with us today.
Thank you so much for asking me. I appreciate it.
Every day across America, excess food is gathered by a network of good people at local food banks, giving hope to millions of children who struggle with hunger. They've earned their wings, and you can too. Together, we can solve child hunger. Support Feeding America and your local food bank at feedingamerica.org.
And then from this angle, it all makes a star.
I'm a teacher. Let me tell you what I make. I make learning a privilege, not a chore.
Show up
and frustration a tool, not an obstacle. I make working hard seem easy and giving up impossible.
And then we're going to turn the lights and everybody look up.
I make an old subject feel like a fresh thought.
What's your reaction gonna be? Yeah, exactly.
And unconventional methods.
Okay, what else?
Common.
This is their world.
There's nothing.
And then they die. Go ahead, go, go, go.
I'm a teacher. I make more.
It's a short ride from your neighborhood to your naturehood. To find a neighborhood park or green space near you, visit discovertheforest.org.